Bipolar affective disorder is defined by the Oxford and Maudsley guidelines as a primary mood disorder. This means mood dysregulation is the primary pathology, not secondary to another condition. It is characterized by the recurrence of distinct mood episodes, periods of abnormally and persistently elevated, expansive or irritable mood lasting at least days to weeks, alternating with periods of depressed mood. Between episodes there may be periods of euthymia, normal mood. The episodes are discrete, not continuous. They have clear onset and offset. During episodes there is marked functional impairment, inability to work, maintain relationships, or care for self. The etiology is multifactorial, biological, neurotransmitter dysregulation, genetic, 70 to 80% heritability, and environmental, stressor, sleep disruption. This is a lifelong condition. Remission is achievable with treatment, but relapse is common without maintenance therapy. Epidemiologically, bipolar disorder affects 1 to 2% of the population in its narrowest definition. The broader bipolar spectrum, including subthreshold presentations, affects 3 to 5%. This makes it a common condition encountered regularly in clinical practice. Unlike unipolar depression, which is twice as common in women, bipolar disorder affects males and females equally. Age of onset is typically late adolescence to early adulthood, 18 to 25 years. This is a critical period developmentally, which contributes to functional impairment. Earlier age of onset predicts worse prognosis and greater chronicity. Comorbidity is high. ADHD occurs in 18 to 20%, reflecting shared neurodevelopmental vulnerabilities. Substance use disorders occur in 50 to 60%, sometimes as self-medication, sometimes contributing to episodes. Anxiety disorders occur in 60 to 70%, often preceding mood episodes. These comorbidities complicate presentation and treatment. Bipolar disorder is among the most heritable psychiatric conditions. Twin studies show monozygotic concordance of 70 to 90%, dizygotic 20 to 30%. This demonstrates strong genetic loading. Family studies show first-degree relatives have 15 to 25% lifetime risk. If both parents are affected, risk rises to 50 to 75%. The inheritance pattern is polygenic. Multiple genes contribute small effects. Key genes include BDNF, involved in neuroplasticity, COMT, affecting dopamine catabolism, serotonin transporter polymorphisms affecting serotonin reuptake, and calcium channel genes affecting neuronal excitability. However, genetics is not destiny. Environmental factors modulate expression. Childhood trauma increases penetrance of genetic risk. Chronic stress accelerates age of onset. Sleep disruption is perhaps the most potent trigger, capable of precipitating episodes in genetically loaded individuals. The monoamine hypothesis, extensively reviewed in Stahl's Neuropharmacology, identifies dopamine dysregulation as central to bipolar pathology. In mania, mesolimbic dopamine is elevated. This explains heightened reward sensitivity and the sense of invincibility. Grandiose ideation reflects dysregulated approach motivation. Mesocortical dopamine can be paradoxically low in severe mania, explaining cognitive slowing and psychotic features despite overall dopamine elevation. This dissociation, high mesolimbic, low mesocortical, is key to understanding bipolar neurobiology. In depression, dopamine is generally low, especially in the mesocortical pathway, contributing to anhedonia and amotivation. Dopamine agonists, stimulants, cocaine, levodopa, can precipitate manic episodes in susceptible individuals. Dopamine antagonists, primarily antipsychotics, are the first-line treatment for acute mania precisely because they reduce dopamine transmission. The Stahl model emphasizes D2 occupancy. 65 to 75% occupancy is therapeutic. Occupancy above 90% does not improve efficacy but increases extrapyramidal side effects. Serotonin dysfunction in bipolar differs from unipolar depression. In unipolar depression, the deficit is clear. Low serotonin causes depressed mood and reduced motivation. In bipolar, serotonin is dysregulated rather than simply reduced. The fluctuations between elevated and low states suggest abnormal regulation of serotonergic systems, particularly involving 5-HT1A autoreceptors, which normally provide feedback inhibition. In depression, serotonin is low, contributing to depressed mood. In mania, serotonin fluctuates abnormally, contributing to irritability, aggression, and impulsivity. 5-HT7 receptors are involved in circadian rhythm regulation. Dysfunction of these receptors in bipolar disorder contributes to sleep-wake cycle disruption, which is both a symptom and a trigger of episodes. SSRIs are problematic in bipolar disorder when used without mood stabilizers because serotonin enhancement can destabilize mood, leading to rapid cycling or manic switching. The Maudsley guidelines explicitly recommend SSRIs only in conjunction with mood stabilizers for bipolar depression. Norepinephrine dysregulation is the third pillar of the monoamine hypothesis in bipolar disorder. In mania, norepinephrine is elevated, explaining the hyperarousal and decreased need for sleep characteristic of the state. The person feels alert, energized, and reactive. This elevated norepinephrine also contributes to anxiety and irritability. Many manic patients are irritable, rather than purely euphoric. In depression, norepinephrine is reduced, explaining fatigue and psychomotor slowing. Concentration and attention are impaired. The behavioral slowing is not just mood-related but reflects norepinephrine involvement in motor and attentional control. The locus coeruleus, the primary norepinephrine-producing nucleus, shows dysfunction in bipolar disorder. This dysregulates the arousal attention systems. NDRIs like bupropion are problematic in bipolar because they increase norepinephrine alongside dopamine, potentially destabilizing mood. The Maudsley guidelines caution against bupropion monotherapy in bipolar, particularly bipolar I. The HPA axis is dysregulated in bipolar disorder. Normally, the hypothalamus releases CRH, which stimulates the pituitary to release ACTH, which stimulates the adrenal cortex to release cortisol. Cortisol provides negative feedback through glucocorticoid receptors. In bipolar disorder, this feedback system is impaired. Cortisol levels are often elevated and the normal diurnal rhythm, high in the morning, low in evening, is lost. Hyperactivity of the HPA axis contributes to metabolic effects, weight gain, metabolic syndrome, immunosuppression, and cognitive dysfunction. Cortisol directly affects hippocampal function, contributing to memory problems and depression. Acute stressor precipitate episodes. Mood destabilization in response to psychosocial stressor is well documented. Chronic stress accelerates the frequency of mood episodes and shortens the interval between them, a phenomenon called sensitization. Early life trauma increases the lifetime burden of mood episodes and worsens prognosis. Therapeutic interventions target HPA axis stabilization through stress management, sleep protection. Sleep loss acutely activates the HPA axis, and psychosocial interventions. The circadian system is fundamentally dysregulated in bipolar disorder. The phase advance hypothesis suggests the internal clock runs fast, causing misalignment with external 24-hour cycle. Sleep architecture shows abnormalities, shortened REM latency, which is unusual in mania. Depression typically shows shortened REM latency, mania does not. Slow-wave sleep is disrupted in both mania and depression. Sleep deprivation is perhaps the most sensitive precipitant of mania in bipolar patients. Losing even one night of sleep can trigger a manic episode. This sensitivity is unique to bipolar disorder. Sleep restriction therapy, deliberately inducing sleep deprivation, has been studied as treatment for depression, but is dangerous in bipolar because of mania risk. The clinical implication is clear. Sleep protection is a cornerstone of maintenance. Sleep hygiene is non-negotiable. Lithium stabilizes circadian amplitude and improves sleep architecture. Some anticonvulsants, particularly valproate, improve sleep quality. Bright light therapy and melatonin address circadian dysregulation directly. These chronobiological interventions are increasingly recognized as important adjuncts to pharmacotherapy. The DSM-5 criteria for mania, aligned with ICD-11 definitions, require a distinct period of abnormally elevated, expansive, or irritable mood lasting at least 7 consecutive days. Note the and/or conjunction. The mood must be abnormal and sustained. This distinguishes mania from normal elation or brief excitement. 3 key features. The mood elevation is distinctive, noted as such by observers. It is expansive, the person wants to engage with everyone and do everything, or it is markedly irritable, quick to anger, easily provoked. Decreased need for sleep is pathognomonic, not insomnia. inability to sleep despite trying but genuinely needing less sleep and feeling rested. A person sleeping 2 to 3 hours and feeling completely refreshed is pathological. Pressured speech reflects the racing thoughts. Flight of ideas jumping between loosely associated topics occurs. Distractibility is marked. Goal-directed activity increases. More work projects, more social engagement, more productivity. But much is unrealistic. Risky behavior. The person spends money impulsively, uses substances, drives recklessly, engages in uncharacteristic sexual behavior. These behaviors reflect poor judgment due to amygdala activation and prefrontal cortex hypoactivity. The episode requires is greater than or equal to 3 symptoms if mood is elevated, expansive, or is greater than or equal to 4 if mood is primarily irritable, because irritability alone is less specific. The DSM-5 criteria for depressive episodes require is greater than or equal to 2 weeks duration, with is greater than or equal to 5 symptoms, including core symptoms of depressed mood or anhedonia. This 2-week threshold distinguishes clinical depression from normal sadness. Depressed mood in bipolar depression is often described as empty rather than sad, a loss of the capacity to feel anything, not just a loss of positive feeling. Anhedonia is the loss of pleasure in previously enjoyed activities. It is not lack of motivation to try, it is that trying brings no reward. Vegetative symptoms accompany mood. Appetite changes, weight changes, sleep disruption. Hypersomnia is characteristic of bipolar depression. Patients sleep 12 to 16 hours and still feel unrefreshed. Psychomotor changes are observable, not subjective reports but actual changes in speech rate, movement, activity level. Retardation, slowing is more common in bipolar depression. Agitation occurs but is less characteristic. Fatigue is often described as physical heaviness. Concentration is impaired. Guilt is often irrational and pervasive. Suicidal ideation is common in bipolar depression and carries high risk. The criteria distinguish bipolar depression from unipolar depression clinically. However, the symptoms are similar. The distinction lies in history of mania, hypomania. The Maudsley guidelines, which align with NICE guidance, recommend antipsychotics as first line for acute mania due to superior efficacy compared to mood stabilizers for acute symptom control. All 4 recommended antipsychotics, risperidone, olanzapine, quetiapine, aripiprazole, show equivalent efficacy, approximately 70 to 80% response rates in acute mania. Selection depends on side effect profile and comorbidities. Risperidone, moderate prolactin elevation, moderate metabolic effects. Olanzapine, higher metabolic risk but excellent efficacy. Quetiapine, very sedating, useful if agitation, insomnia prominent, lowest EPS risk. Aripiprazole, minimal weight gain, minimal prolactin elevation. Antipsychotics work via D2 dopamine antagonism, rapidly reducing mesolimbic dopamine elevation. Lithium is an alternative first line for acute mania, with 60 to 70% response rate but slower onset, days to weeks versus hours for antipsychotics. Valproate is effective for acute mania, especially in rapid cycling. Lamotrigine is ineffective for acute mania, better for bipolar depression. Benzodiazepines like lorazepam provide rapid behavioral control and reduce agitation, facilitating compliance with antipsychotics. Hospitalization is indicated when mania is severe with psychotic features, when the patient is at risk, reckless driving, substance use escalation, or when compliance cannot be ensured outpatient. Bipolar depression requires fundamentally different treatment from mania. Antidepressants are avoided as monotherapy because they carry significant risk of mood switching, manic induction, or rapid cycling in bipolar patients. This is a key distinction from unipolar depression treatment. Mood stabilizers are the foundation. Lithium is the gold standard, FDA approved for bipolar depression, with the strongest evidence base and unique anti-suicidal properties, 30% reduction in suicide risk. Lamotrigine is increasingly preferred for bipolar II depression due to excellent efficacy and minimal side effects. The Maudsley guidelines recommend lamotrigine as NICE grade A for bipolar II disorder. Valproate is less effective for depression than mania but helps some patients. Antipsychotics with antidepressant properties, quetiapine, aripiprazole, luridone, are FDA approved for bipolar depression and represent another first-line option. They work through mechanisms beyond dopamine antagonism, including serotonergic effects. If SSRIs are used with caution, They must be added only after mood stabilizers are established at low doses with frequent monitoring. Psychotherapy is essential. CBT targeting depressive cognitions, IPTE, interpersonal and social rhythm therapy, addressing sleep-wake cycle and social rhythms. Lithium is the only psychotropic medication with proven anti-suicidal efficacy, a 30 to 50% reduction in suicide risk across multiple randomized trials. This unique property makes it the gold standard maintenance treatment despite tolerability challenges. The mechanism of action is complex, involving multiple pathways. It inhibits inositol monophosphatase, which disrupts the phosphatidylinositol second messenger cascade, abnormally hyperactive in bipolar disorder. It upregulates BDNF, brain-derived neurotrophic factor, supporting neuroplasticity and neuroprotection. It reduces norepinephrine-driven CAMP accumulation. It stabilizes circadian rhythm amplitude. It has anti-inflammatory and neuroprotective properties. The therapeutic window is narrow. 0.5 to 1.2 mmol/L is therapeutic, but toxicity risk rises steeply above 1.5 mmol/L. Acute toxicity, lithium toxicity, presents with coarse tremor, confusion, ataxia. Chronic toxicity risks nephrogenic diabetes insipidus, polyuria, polydipsia, hypothyroidism, and fine tremor. Renal function must be monitored baseline and annually, eGFR. Thyroid function must be monitored, TSH. Lithium is teratogenic, Epstein anomaly risk in the first trimester, though less than historically believed. The Maudsley guidelines recommend lithium as gold standard but acknowledge tolerability barriers that drive patients to alternatives. Valproate, sodium valproate, and lamotrigine are second-line mood stabilizers, each with distinct efficacy profiles and mechanisms. Valproate is a GABAergic agent. It enhances GABA synthesis and inhibits GABA catabolism, increasing inhibitory tone. This is effective for acute mania 60 to 70% response, and useful for rapid cycling. However, it is ineffective for depression. Side effects are significant. Weight gain, average 5 to 10 kilograms, tremor, hepatotoxicity requiring LFT monitoring, and teratogenicity, 10 to 20% risk of neural tube defects, developmental delay. It is contraindicated in pregnancy. Lamotrigine is a glutamate antagonist. It blocks sodium channels and reduces glutamate release, decreasing excitatory transmission. It is highly effective for bipolar depression, especially bipolar II, but completely ineffective for acute mania. The major side effect is risk of Stevens-Johnson syndrome, rare, approximately 0.1%, requiring slow titration, particularly when co-prescribed with valproate. Lamotrigine is weight neutral and well tolerated. The Maudsley guidelines position lamotrigine as first line for bipolar II disorder and bipolar depression. Valproate is first line for rapid cycling and acute mania when antipsychotics are contraindicated or ineffective. The duration of maintenance treatment reflects relapse risk. The Maudsley and NICE guidelines recommend minimum 12 months of maintenance after first episode. After a second episode, 2 to 5 years is recommended. After 3 or more episodes, lifelong maintenance is the consensus recommendation. This reflects the natural history. With each episode, relapse risk increases and the interval between episodes shortens. Sensitization. Maintenance pharmacotherapy is essential. Relapse rates with ongoing treatment are 30 to 40%. Without medication, rates exceed 90%. Medication continuation is non-negotiable. Patients who discontinue typically relapse within 6 months. Doses during maintenance may be lower than acute treatment once stabilization is achieved, but the principle is, the dose that maintains stability in the acute phase should be continued. Lithium is superior for relapse prevention, with 1-year relapse rates of 26%, better than any other agent. Valproate shows 42% relapse rates. Antipsychotics vary, with most showing 40 to 60% relapse rates. Psychosocial interventions during maintenance. Regular appointments with psychiatrist, therapist, psychoeducation about relapse warning signs, family therapy to reduce expressed emotion, sleep hygiene emphasizing consistent sleep schedule, stress management, are equally important as pharmacotherapy. Clinical monitoring is essential for optimizing outcomes. In acute mania, initial response appears within days. Behavioral control is seen first. Mood elevation begins to level and irritability decreases. By week 2, significant symptom reduction should be evident. By week 4, a judgment is made about adequacy of response. If inadequate, doses are increased or agents are changed. Antipsychotics are faster response in days to weeks than mood stabilizers, weeks to months. In acute depression, response is slower, weeks 2 to 4 before mood lifting begins. Full response is expected by 8 to 12 weeks. Patience is required. Premature agent switching is common and should be avoided. Maintenance monitoring is ongoing. Appointments are scheduled every 1 to 3 months. Validated scales track mood. PHQ-9 for depression, MDQ, mood disorder questionnaire, for hypomania, mania. Adherence is assessed directly and non-judgmentally. Side effects are evaluated. Medical monitoring includes weight, average 4 to 5 kilograms gain with olanzapine, 2 to 3 kilograms with risperidone, metabolic parameters, baseline and annually, glucose, lipids, prolactin, baseline and periodically depending on antipsychotic, ECG if QTC prolonging agent. Lithium levels are monitored frequently at initiation, then every 3 to 6 months once stable. Early warning signs of relapse are taught to patient and family. Sleep disruption is the most sensitive. A patient who normally sleeps 7 hours, suddenly needing only 4 hours is at high risk for mania. Mood elevation beyond normal fluctuations, energy changes, social changes, impulsive behaviors are all warning signs.